you, Dr. Verma, and very good morning to all of you. Vein occlusions, as we all know, the branch retinal vein occlusion and the central retinal vein occlusions both actually have very different perspectives as far as their prognosis, outcomes and sequelae are concerned, but there are a lot of similarities as well. So I'll not go in this short time to discuss differences between the two of them, but on the whole the surgical indications pretty much amount to similar things where both are concerned. The mainstay of treatment as far as both of these are concerned at the moment remain with anti-VEGF injections or steroid or long-acting steroid depot preparations, and adjunct laser as and when required is what is today's strategy of treating them. As long as the media is clear, you are seeing them in an acute phase and it's not gone into its sequelae where it might require various surgical indications. We also need to know if at the time you're seeing them, is there ischemia present or not, because that also decides about the laser that you do or a sectoral or a grid, so that you reduce the chances for the sequelae which might induce you to have the patient for surgery at a later time because of a hemorrhage coming in or proliferations or a neovascular glaucoma that you are concerned with. So these are the things that we need to look at when the patient presents at an early phase to you, so that you don't as long as you can see the media, there is no surgical indication, you don't let it go into an indication at a later stage. So make sure that we do all these things as far as the anti-VEGF, the laser is concerned, and only when you have a vitreous hemorrhage which is non-resolving. Previously one used to wait for 3 to 4 months, but nowadays I don't think we wait more than a month if we have seen the patient and then it's not resolving, or if the patient already gives you a history of a month that he's had a visual loss and is not clearing up, or a subhyaloid hemorrhage which is grossly blocking the area, a tractional detachment that you see, or an impending traction around the macula, and of course a chronic macular edema. These are the common indications that one would consider for doing surgery in these cases. I'll just show you a few examples of situations which we encounter when we do vitrectomy for vitreous hemorrhages or subhyaloid hemorrhages in these cases. The main aim is to clear the hemorrhage, the whole vitreous, and then assess what is the damage behind. A lot of times you don't even know that there is a vein occlusion behind, although if the patient is a non-diabetic, non-hypertensive at times and just comes with a hemorrhage, the elderly age group, vein occlusion remains the most common cause. So you need to then assess, once you clear, what is the damage behind which sector, and then you do a proper laser to that area. And if there is an edema, then you need to take care of that edema. If there is a thickening, then maybe you might want to do a ILM peel or an ERM peel and then give an adjunct anti-VEGF or a steroid at the end of surgery. So this remains the mainstay of a classic case where you might have a hemorrhage which is non-resolving, and that could be in different grades. Sometimes it's a dense hemorrhage, sometimes it's just enough that you cannot really treat it externally and you need to laser. So always you'll not find an extensive hemorrhage. It could be localized to areas which because of which your laser cannot manifest, and then you need to clear up the media. And also in terms of recurrence, history of recurrence of hemorrhages, if the patient already has had history of that, then also you don't want to wait even if there is a mild hemorrhage which has come up which is obscuring your view to treat those conditions. And when you clear up, you many times see these sclerosed vessels which indicate that this has been long standing and probably the patient has missed it earlier when the actual vein occlusion occurred and has noticed it only now when the hemorrhage was enough to block the view in these situations. There is a large subhyaloid hemorrhage which also comes in typically at times in these cases and would require a surgical removal so that you can assess the damage behind, also clear the visual acuity. Otherwise the deposit of such a large hemorrhage slowly causes toxicity to the macular area, and if you clear it up at a much later date, the visual prognosis might not be as good in these cases. So once again we clear up and assess what is the cause, where is the source. I think the most important part is to look at the source, and you will find either a sector which is involved. At times you'll see multiple sectors which are involved. You might see frank proliferation, sometimes you see them and partly they are fibrosed. Sometimes you see a previous laser mark that the patient has been treated in the past for vein occlusion, but then of course at some point it further went in to cause the hemorrhage. At times when this is dehemoglobinized blood, so it's probably been for some time, and then when you clear it up, you see a TRRD kind of a situation. There is a proliferation with a hole next to it, which has lifted this part of the retina underlying the hemorrhage. So at times you might encounter a tractional detachment. Your ultrasound also might have guided you. Central area, and here we put in perfluorocarbon to assess the traction, and then of course remove the ILM which is overlying, which would help release the traction to some extent, because there is an extensive proliferation very close to the fovea, which we after cutting off segmented and then diathermized, but the residual traction is very close to fovea. So here it would help to remove the ILM, and the perfluorocarbon is useful in such cases to assess that and then remove this. So these were the common indications that we show. Just a passing mention at the end to a surgery which we used to do at one point a couple of years back, but now has totally gone out of vogue since the anti-VEGFs have come in. In sheathotomy, we used to go in between the arteriovenous sheath and just relax it with a bent MVR blade and increase the perfusion of that area. So this is one of those older pictures which I'm just showing you for pre and a post sheathotomy, where we used to assess the arteriovenous junction, also angiographically see that, and then go in and create a sheathotomy. Similarly, for a central vein occlusion, there was radial optic neurotomy, where we used to give this a blind incision with a MVR through the margin of the disc, which seemed like a very gory procedure at that time, but was being done before the anti-VEGF area. So this is also one of the pre and post. You see these two stabs which at times form choriovenous anastomosis, which was leading to the improvement in a lot of these cases. But then it was a blind procedure, and we did not know for sure what was happening. And soon when the anti-VEGFs came in and the visual acuities were improving much better, I think we've almost given it up for now till something new comes in. Thank you very much.